Good morning or afternoon, wherever you are, everybody. Welcome to this, our webinar today. The webinar is Young Onset Stomach Cancer by Dr. Melissa Lumish. And we will begin in just a second. Forgive me, I'll be turning off my camera for this portion. Thank you to our generous sponsors for making today's program possible. Platinum sponsors Bristol Myers Squibb, Merck, and Taiho Oncology. Bronze sponsor Arcus Biosciences. Silver sponsor Amgen, and copper sponsor Lilly Oncology. First, I will share information about stomach cancer and Debbie Stream Foundation. Then we will hear a presentation on young onset stomach cancer from Dr. Melissa Lumish. A Q&A session will follow the presentation. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is the second leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate of between 20% and 30%, depending on the country. Many patients are asymptomatic during the early stages of stomach cancer, leading to the late diagnosis. Debbie Stream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at debbiestream.org. Pictured here is Debbie Zellman, the founder of Debbie Stream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in April 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many recurrences. Unfortunately, Debbie passed away on December 23, 2017 at the age of 50 after a 9.5-year battle with cancer. As an organization, DDF continues her important work and legacy. In a few short years, DDF has achieved many great milestones. We have 32 chapters across the United States, including Canada and Germany. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors during disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We also have provided $2 million in research grants to date. Patient advocates come together each year at our annual Stomach Cancer Capitol Hill Advocacy Day to secure funding from the Department of Defense's peer-reviewed cancer research program, which allocates funds for stomach cancer research. Earlier this year, in March, we traveled to Washington, D.C. with more than 130 advocates and held 180 meetings with lawmakers to inform them that we need more funding for this deadly disease. We're proud to say that this year was our largest turnout yet. We hope that you'll join us this coming year as we let our Congress know that we need a cure. You can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions at the conclusion of the presentation as time allows. Dr. Melissa Lumish is a medical oncologist at University Hospital Stedman Cancer Center with expertise in gastrointestinal cancers. Her specific areas of interest are early onset gastrointestinal cancers, which are young adults under the age of 50, the use of immunotherapy, and the role of microbiome in cancer growth and treatment. Before she was recruited to join University Hospitals, Dr. Lumish was a medical oncologist at Memorial Sloan Kettering Cancer Center in New York City. Dr. Lumish earned her undergraduate degree from Cornell University and her medical degree from New York University School of Medicine. She completed an internal medicine residency at Massachusetts General Hospital in Boston, Massachusetts, and a fellowship in hematology and medical oncology at Memorial Sloan Kettering Cancer Center. Dr. Lumish's research has been published in the New England Journal of Medicine, Journal of Clinical Oncology, JAMA Oncology, Journal for Immunotherapy of Cancer, American Journal of Surgery, Journal of Surgical Oncology, and Scientific Reports. She was one of the researchers involved in a small but groundbreaking clinical trial published in the New England Journal of Medicine, which showed that patients with mismatch repair deficient locally advanced rectal cancer can achieve a complete clinical response with 6 months of treatment with an immune checkpoint inhibitor without radiation surgery or chemotherapy. Among other honors and awards, Dr. Lumish is the recipient of the American Association for Cancer Research 2021 Doreen J. Putra Cancer Research Foundation Scholar in Training Award, Annual Meeting Merit Award, American Society for Clinical Oncology, Donald L. Morton Award, 9th Annual Journal of Surgical Oncology Award, and the Conquer Cancer Young Investigator Award with the American Association of Clinical Oncology. We will now begin our webinar with Dr. Lumish.
Okay, great. Thank you so much for that thorough introduction and for sharing the background about Debbie's dream. It's really an honor to be here to be able to speak with you today, and I look forward to sharing some information today about young onset stomach cancer, and then hearing some questions and discussion toward the end. So I, just to start, do not have any disclosures. So the question that comes to mind is, why now? Why are we talking about young onset gastrointestinal cancer in general? And what you've probably seen most in the news is many headlines looking at young onset colorectal cancer, showing troubling rise in colorectal cancer under age 55, questioning whether things that we're doing to our bodies, like intake of sugary drinks, are playing a role, whether screening should be starting earlier for colon cancer, and seeing many well-known celebrities being diagnosed with colorectal cancer at an early age. That skipped ahead a little bit. But what we're also starting to see now is that this broader discussion about early onset gastrointestinal cancers in general, specifically including stomach cancer. And obviously we know that the founder of this organization was a young woman with metastatic gastric cancer. And what we're seeing now, this is an article from the National Geographic, Why is Stomach Cancer Rising in Young Women? Cancer is striking more young people, and doctors are alarmed and baffled, suggesting that even from the medical standpoint, researchers and physicians don't know why this is happening. And then we're seeing that millennials and Gen Xers are facing a higher risk of 17 cancers than previous generations. And why is metastatic stomach cancer on the rise in young adults? And why are we seeing some ethnic or racial subgroups being more affected than others? And this is the reason that for discussing this today. So in any discussion about what we're calling early onset cancers in general, it's important to think about how we're defining that. So in colorectal cancer, this answer is a bit more clear because there's a clear paradigm outlining screening guidelines and the anticipated age of onset. So we expect that if we were to start screening at age 50, we'd be detecting precancerous lesions and we'd be preventing cancers. So when we're seeing patients actually come in at age 45 or 50 with colorectal cancer, that's clearly earlier than we would expect. But for stomach cancers and esophageal cancers, which are often grouped together, that paradigm of what's early onset and how long does it take for disease to develop is a lot less clear. So we're going based on the paradigm set by colorectal cancer that early onset is prior to age 50, but in reality, we don't know exactly how long this process of going from a normal stomach and being exposed to some potential environmental or inflammatory factors in the intestines, which is what's shown here, or in the stomach, how long that takes to develop stomach cancer. So perhaps seeing stomach cancer at age 55 or even age 60 is technically early. So there, even just that definition has a lot of open-ended questions in the field. But what we'll talk about today is early onset stomach cancer occurring prior to age 50 based on that colorectal paradigm. What's the scope of the problem? What are the clinical and molecular characteristics of early onset stomach and esophagus cancers compared with those that occur at a later age? And then we'll discuss some of the potential drivers of early onset stomach cancer, acknowledging that a lot of these questions really do remain unanswered. And from that standpoint, we'll look at etiology and risk factors, as well as some potential strategies of how we might think about stopping this rapid increase in early onset stomach cancer. And then lastly, we'll talk a bit about patient-focused approaches and how we can use multidisciplinary management through a dedicated center for young individuals with gastrointestinal cancers to improve both research and the clinical treatment of these patients. So when we think about the cancers that are most common in the United States, again, colorectal cancer you'll see is very high on the list here, the third leading cause of cancer in the United States in men and in women. But the reality is that stomach cancer does account for over 1%, 1.5% of new cancers diagnosed in the United States each year. And esophagus cancers are up there as well. So this is also important to acknowledge in the context of the fact that cancer incidence rates are decreasing overall. So these are the lines shown here are a variety of different types of cancers and their incidence rates per 100,000 people, starting in 1975 all the way on the left to 2020 on the right. And you can see aside from the spike in prostate cancer in men, which was explained by our increased ability to detect prostate cancer, almost all types of cancer are either stable or decreasing. Most notably, you'll see this green line for colorectal cancer, the red for lung cancer. And the same is true when we look on the right for women. Aside from breast cancer, which has been about stable, again, due to probably in part our ability to detect it, we're seeing most cancers decrease or stabilize over the last few decades. However, the incidences of colon and rectal cancer are absolutely increasing in younger adults. So on the left, you see the trends for patients over age 60, going up by less than 1% per year, or even going down for rectal cancer. And when we look in this age 20 to 40 group on the right, we're seeing an increase in colon cancer at the top here and a dramatic increase in rectal cancer. And that's relevant. I know here we're talking about stomach cancer today, but what we're seeing is that within the gastrointestinal tract, there are certain sites that are being more likely to develop cancer in these younger individuals compared with other sites in the GI tract. And this data that I'm showing here is from prior to 2000, but the reality is that since then, in the last 25 years, we're still seeing a rise in early onset colorectal cancer. And if we shift gears and think about early onset stomach and esophagus cancer under age 50, those are also rising. So though the numbers do remain quite low, since the overall prevalence is lower compared to colorectal cancer or breast cancer, what you're seeing here is some graphs looking at the age-adjusted incidence of gastric cancer and the age-adjusted ratio of early onset compared to average onset gastric cancer. And although, again, the numbers are small, you're seeing a dramatic increase since 2000 in the age-adjusted incidence, meaning like per age, for someone's age, the increase is much more dramatic in those under age 50, whereas it's stabilizing or even decreasing in those in the older age groups. And then on the right, you're seeing the same thing for esophagus cancer. So the under 50 group is this dark black line here, which is only slightly trending up. But again, we shouldn't really be seeing a rise in esophagus cancer or stomach cancer in young individuals. And if we've also seen a threefold increase in early onset gastroesophageal junction cancer. So those are cancers that are rising between the stomach and the esophagus in the last several decades. So that brings us to part one of the discussion, which is how do we characterize early onset stomach cancer? What does it look like compared to the average onset counterparts. So what I'm showing here is the distribution of early onset colorectal cancer, which again has been studied a bit more. And although colorectal cancer incidence has stabilized in high income countries among those over age 50, it's increased rapidly in individuals under age 50. And what you're seeing here is age standardized incidence rates, meaning that the way that it's being presented is adjusting for age. So if we said every country had the same number of people under age 50, what would the incidence look like? And the darker the color, the higher the prevalence of early onset colorectal cancer. And you'll see that while the rates are high in the United States here, this is a global phenomenon. And when we look at stomach cancer, we're seeing similar trends, that early onset stomach cancer is a global phenomenon. So what you're seeing here is that the incidence rates for early onset gastric cancer are shown with the lighter blue areas representing regions of higher incidence. So on that prior map, the darker areas were higher incidence, but here the lighter the color, the higher the incidence. And we're seeing that it's highest in South America and East Asian countries, including China and Japan. But again, this is not isolated to one region of the world, and the worldwide incidence rate of early onset gastric cancer or stomach cancer was predicted to increase substantially from 2020 to 2035. So we're in the midst of this rapid rise. And we do see that early onset gastric cancer is predicted to increase most in China and Korea. And the incidence rates were predicted to increase substantially from about 9 or 10 per 100,000 in 2019 to 17 or 21 per 100,000 in 2035 in China and Korea. And that's distinct from Japan, where the rates were expected to decline. And in Australia and the United States, the rates are predicted to change only slightly or remain stable. So there does, although it is a global phenomenon, there do seem to be some regional potential environmental or genetic impacts on the regions of the world in which we're seeing the greatest rise in early onset stomach cancer. So the next question that comes up is, if we understand to some extent the distribution worldwide, what are some of the features that distinguish early onset stomach cancer from stomach cancer that develops in individuals over age 50? And this, what I'm showing here is some data from a single institution study that we did at Sloan Kettering, which is a population of patients mostly coming from the New York City area, but it does draw some patients from outside the region. And what we did was looked at the clinical characteristics of early onset stomach and esophagus cancer occurring prior to age 50 in about 219 patients. And we compared that to those with average onset over age 50. That was about 904 patients. And what we found was that there was a higher percentage of a gastric or stomach primary tumor site in the early group. So that's shown by these yellow and green bars here. And the early group under age 50 is the lower bar. And you can see the yellow component is much larger in the early group compared to the average onset group. So what that's telling us is that if we lump together gastric or stomach and esophagus cancer and look at them as a whole, the younger group is going to have more stomach cancer compared to the older group. The other thing that's interesting is that we previously thought of some of these cancers as male predominant, but what you'll see is that in this yellow, the yellow and orange bars here, is that in the early group, the proportion of women or females is higher, 39% compared to 28% in the average onset group. And that does kind of bring us back to some of those headlines that I showed initially, stating that we're seeing this rise in early onset gastric cancer, specifically in young women. And that's alarming because, again, we don't know why that's the case. And then if we look at the racial breakdown here, the population of patients that we examined in this study was predominantly white based on the region, but what you do see is that there's a higher proportion of Asian individuals in the early onset group, 16% compared with only 9% in the average group. And then lastly, if we're looking here at in this bottom part with the dark and light blue bars is we're comparing what's the type of cancer, the type of stomach cancer. And we're seeing more of what's called signet ring cell or diffuse type cancer in the early group, 31% compared with only 9% in the average group. Excuse me. And again, that might speak to some of the underlying biology. And then on the right here, again, showing some of that same information. If we look specifically in the early onset group at the stomach as opposed to the esophagus group, this medium blue color is the signet ring cell or diffuse type. And although that has been associated with inherited predisposition to stomach cancer, that's not what we are seeing here. We are seeing increased diffuse type, signet ring cell type cancer, regardless of the inherited predisposition for cancer. The next thing that we looked at is if we look at early onset stomach and esophagus cancer, what are some of the presenting symptoms? And do these differ at all from those with what we call average onset disease? And the early onset is shown by the red bars, while the average onset is shown by the blue. And you'll see that the older patients, the average onset, are more likely to present with weight loss and difficulty swallowing, probably because these tumors are more likely to be in the esophagus, whereas the younger individuals present with more nonspecific symptoms like pain and indigestion. Excuse me just for one second. What we're also seeing then, aside from the symptoms being different, is we're seeing a different distribution of the disease. So the question is, if a patient comes in with advanced stomach cancer, is it more likely to present with involvement of the liver or different parts of the body? And what we're seeing is that the dark black bars here are peritoneal metastases or metastases to the abdominal cavity. And those are much more common in the early onset group and also more common in stomach cancer as opposed to esophagus cancer. And then when we look at the breakdown of these cancer types, and we try to look at not the genetics of the person, but the genetics of the cancer itself, how do those differ between early and average onset? And what we find is that these cancers in the younger individuals tend to have lower mutation burden in the cancer. So fewer mutations shown here on the left, and also lower fraction of the genome altered. So it's just another measure of instability of the genetics of the cancer. And the reason that's also relevant is because some of these components do have treatment implications, like may have some influence on whether the tumors may respond to some of our novel treatment strategies like immunotherapy. And if it's a lower tumor mutation burden, there's less likelihood that it's going to respond to immunotherapy. And then again, on the right here, also speaking to some of those genetic subtypes, you may have heard of a condition called Lynch syndrome, in which the tumors have a lot of mutations and can respond to immunotherapy. That's shown by this orange bar here, and this much lower fraction of the early group compared to the average group. We also looked specifically in this population at specific gene alterations in the early onset versus average onset group, trying to see if the cancers develop differently. The way that cancer develops is often by accumulating a lot of abnormalities in the genetic material of the tumor. And we do see a few mutations that I listed here being more common in the early onset group, But on the whole, if we look kind of at a 30,000-foot view, these tumors are not markedly different when we account for the site at which they originated, meaning which part of the stomach or esophagus. So this doesn't really shed light on why this phenomenon is happening. And then the last thing we looked at in this data set that I'm showing here is overall survival, meaning from the time someone's diagnosed with advanced or metastatic stomach cancer, how long do they survive? And when we compare the average onset and early onset groups overall, including both stomach and esophagus cancer, you'll see that these two lines overlap each other, so there's not much of a difference. But if we break it down by early onset stomach cancer, which is shown in this light orange bar, and early onset esophagus cancer in the red, and then the average ones in blue, you'll see that the lower the curve dips, the worse the survival is. And so you'll see that the worst survival is in the early onset gastric group. So these are the patients who we're talking about, the young women who have spread to the belly cavity, who have this diffuse type or signet ring cell type that we can't fully explain. These are the individuals who are also doing the worst when we look at overall survival in our group, in our data set. This is obviously quite limited by the fact that it was a very homogeneous population of patients and it was only one institution. What we do know from other broader studies is that early onset gastric cancer does disproportionately affect racial minorities. So this table is from a study that examined all patients with stomach and esophagus cancer from 2004 to 2015 from the National Cancer Database. So that was over 150,000 patients. And it categorized patients by under age 50, which I called early onset, and then 50 to 69, and over greater than or equal to 70, which I bucketed together as average onset. And they looked at differences in the tumor and also social and economic factors between the groups. And the most notable finding is that while the early group was 49% white, the average group, looking specifically at this 50 to 69 group, was 66% white. And there was almost double or more than double the proportion of Hispanic patients in the early onset group. And if you look at the numbers here, which I didn't call out specifically, but the Black and Asian population component of the group is also higher in the early onset group. So again, it's unclear whether these are genetic type of factors that are contributing or more social and economic factors that disproportionately affect individuals with different racial backgrounds. But this is a phenomenon that's seen in a large data set across the US. So moving on to the second part of our discussion is what are some of the potential drivers of early onset stomach and esophagus cancer? And I obviously gave the qualification at the beginning that we really don't know why this is happening, but many people have been investigating some of the underpinnings of this and have some hypotheses. So one explanation for the observed rise in gastrointestinal cancers in young individuals overall is something called the birth cohort phenomenon. And what this says is that it's saying that the effect that having been born in a certain time period or having experienced the same life experiences has on development in a group. So the advantage of this kind of cohort modeling is that it can disentangle factors that affect all ages, which are called period effects, like changes in medical practice, from those that vary by generation, which are called cohort effects, as a consequence of behavior changes that might differ from one generation to the next. So the diagram here shows risk factor exposure represented in pink, with greater exposure to whatever underlying risk factor we think of in the cohort born around 1980, compared with those born in 1950. So this pink bar is wider for the 1980 group compared to the 1950 groups, showing exposure to this underlying risk factor that we haven't yet identified, and leading to a higher incidence in gastrointestinal cancers over the course of the lifetime for those born in a given year. So, and when we think about this in the context of colorectal cancer, which has been studied more widely, it's important to note that age-specific colorectal cancer risk has escalated back to the level of those born in 1890 for contemporary birth cohorts. So something about our generational exposure now is bringing us all the way back in time to the level of risk that we saw, a century ago. So what I've shown next here is a diagram from one of the American Society of Clinical Oncology education books, which is a schematic outlining some known risk factors for early onset GI cancer overall, shown in green, and some possible risk factors. But the qualification here is that much of this data comes from colorectal cancer. So we know that some genetic factors, alcohol consumption, smoking, dietary factors, elevated body mass index, and some environmental carcinogens can influence risk of colorectal cancer. And we think that maybe the microbiome and antibiotic exposure can play a role as well. But what we know about early onset gastric cancer is more limited, and is based on some of these single institution studies and some national databases, but we have less information about what could be underlying this. So what I'd like to go into next is what I think are the four kind of big buckets that we need to think about now and also in the coming years and decades to try to uncover why this is happening and intervene. So why is early onset gastrointestinal cancer rising? Proposed etiologies or contributing factors are diet, the microbiome, host diseases like other chronic diseases, and genetic factors. So I'll start by first focusing on the microbiome, which, as you heard, is an area that I've worked on in both colorectal cancer and in stomach and esophagus cancer. And we'll just touch briefly on what data does exist already. So in colorectal cancer, we know that specific bacteria can contribute to colorectal cancer. So what you're seeing here is a little microscopic loop of intestines, and the bacteria live right inside this layer of the intestine in all of us, and that's a normal phenomenon. But the question is whether specific bacteria that live there are causing problems or contributing to cancer development or cancer progression. And there have been a few different strategies that bacteria can use to influence cancer development. So one is inflammation, and there are several bacteria that I listed here that have been shown to be associated with inflammation in the intestines. There's this one bacteria, Fusobacterium nucleatum, which has been associated with a lot of negative effects such as resistance to chemo and inhibiting the immune response, which is a bad thing because we want our body's immune system to fight against the cancer. And then lastly, inducing DNA damage. So at the beginning, I was discussing how cancer often develops due to accumulation of abnormalities in the genetic material of cells. So maybe some of these bacteria are inducing genetic changes that are contributing to the development of cancer. But that's what we know about colorectal cancer. What do we know about stomach cancer? So one main risk factor, or one of the strongest risk factors for stomach cancer, is H. pylori or Helicobacter pylori associated inflammation in the stomach. And what you're seeing here is what has been proposed as the way that H. pylori can play a role in stomach cancer development. So again, you see some of the normal stomach lining here. H. pylori can live in the stomach with other bacteria and can interact with the stomach and eventually cause intestinal metaplasia, which means changes in the intestinal cells, and eventually dysplasia, which is abnormal growth or abnormal development, not just a change, but abnormal cellular changes, and that precedes cancer development. And what we know about this one bacteria so far, the H. pylori, is that we can treat the infection and eradicate it. And if we intervene at the right time, we may actually be able to prevent the cancer from developing or even cause sort of regression towards from cancer back towards more normal tissue. And the interesting thing here is thinking about the two questions about this. One, does the age at which we intervene make a difference? And two, are there other bacteria that we're missing that could be playing a similar role that we haven't quite uncovered yet? And the reason I bring up whether age matters is the intestines and the stomach lining respond differently to exposure to bacteria as we age. And the body has different mechanisms for compensating for abnormalities at different ages. And you can imagine that a young person's body may have more tolerance for abnormalities to occur because the body's overcompensating and readjusting to allow these abnormal cells to exist. Whereas maybe in an older individual, there's less tolerance in the body for that. And that's one way that we might think about how these early onset cancers are occurring, is because the young body can tolerate these abnormal changes. And then the other reason this is relevant is thinking about when should we be looking for H. pylori or other bacteria, and in which population of patients, when is it ideal to try to eradicate it? So those are still open questions. What we also know, in addition to H. pylori, which is the most well-studied bacteria in stomach cancer, is that dysbiosis, or a change in the overall community of bacteria that live in the stomach or the intestines, can contribute to the development of stomach cancer. So there are many different ways, which are sort of outlined by this diagram, that different bacteria can cause inflammation and damage to the genetic material of the stomach, and also tumor growth and evasion of the immune system. So H. pylori may have not only its own effect on the stomach cells, but it may actually cause increase in some other groups of bacteria that are detrimental, and may cause, other good bacteria to have more difficulty surviving in the intestines. And then another component that's been considered is whether we should be looking just at bacteria in the stomach and the intestines, or whether bacteria elsewhere in our body play a role. So there are bacteria that live in our skin, in our mouth, in other parts of all over the body. And should any of these be studied as far as, increasing or decreasing the risk of cancers? And there's one bacteria that they call out here in this diagram, which is a skin bacteria that lives, on normal individuals, but it's been shown to be able to change our body's immune response by making certain fatty acids in patients with inflammation of the stomach. So it's unclear, the role that this may have, but I think we need to think more broadly about how different bacteria in the body are interplaying with each other, and how the role of antibiotics and other things that modulate the immune system could be playing a role. And then lastly, as we've seen in colorectal cancer, there's this bacteria called Fusobacterium nucleatum, which is also found in the stomach, and can be associated with infiltration of different immune cells, and can be associated with a worse prognosis in diffuse type gastric cancer. So this hasn't fully been studied yet, but it's another avenue for future directions. And then wrapping up some of the information about the intestinal microbiome and how this may play a role in our understanding of gastric cancer and our management of it. This is a graphical abstract from a multi-center study that was done in China. And what they did was they took patients with stomach cancer and those with chronic gastritis, which is just inflammation of the stomach, but not cancer. And they looked at a few different groups of these patients, specifically at the bacteria that lives in the intestines and also in the tissue. So they looked at an initial cohort of 50 patients, and then they tested some of their findings in a training cohort and a validation cohort. And what they found was that two specific species of bacteria in the Streptococcus family in the stool were actually associated with more cancer as opposed to inflammation. So the blue components here are the individuals who had just inflammation. The red on the right are those who had actual cancer. And you can see that on this part of the axis here is how much of those two bacteria they had. And the levels of those bacteria were higher in individuals in the red groups, the ones who had cancer. So why is this relevant? Do I think that Streptococcus aeruginosus or constellatus are going to be the new H. pylori? No, but the question is whether these could be biomarkers or things that we look for as early signs of changes that could help us to identify patients with earlier stages of stomach cancer and treat it in a curative way, sooner. Maybe this is an avenue for that. So taking the next steps forward, I've spoken a lot about what's in the literature already, but how can we take this to the next level to try to study this further and understand how different bacteria are playing a role in both treatment response and in developing the cancer. So one way that we're doing this, this is work that I started while I was at Sloan Kettering and I'm still collaborating on, is developing a platform to collect samples over the course of time in individuals with known stomach, esophagus, and colorectal cancer. And the reason this is relevant is that we're collecting stool and tissue and blood at the time that patients are diagnosed, and then over the course of time to try to understand a few things. One, can we use the bacteria to predict who's going to have more aggressive disease that's going to recur or spread? Can we use it to predict who's going to respond to different therapies? And can we use it to better understand how our own body's immune system is interacting with bacteria and the cancer as a whole? So this is ongoing work, and what I've shown next is just an example of how we can use this on an individual patient level to find some interesting and hopefully enlightening results. So what you see here in each column is a patient's, this is all from one patient. You see their individual, each sample is shown by a column. So we collected stool samples at the time of diagnosis, at 5 and 6 months in, 8 months, 11 months, and 15 months in. And what you can see is that each group of bacteria is represented by a different color, and we've collected after chemotherapy with a regimen called FOLFOX, during their maintenance phase of a less intense treatment, and then at the time of progression where they had metastases to the bone. And you see that there are shifts in the different groups of bacteria over time, and these are the things we're trying to capture on a group level. So looking at this on an individual patient basis may not be helpful, but if we take a whole group of patients and look at all the ones who progressed on their treatment, meaning they didn't respond, and try to see which bacteria are most predictive and how can we manipulate that bacteria over time, that could be a potential strategy to try to better understand the disease and treat it. So overall, how can the intestinal microbiome reveal novel associations with early onset stomach cancer? We talked about how specific bacterial species may be associated with early onset stomach and esophagus cancers, but more research is needed. And then we can look at bacterial pathways. What are those bacteria producing? What are they consuming? And see how these factors are associated with the immune response and with development of these early cancers. And I think this is an interesting avenue because it's one that hasn't been fully explored. And all of the avenues that we've taken so far to try to understand the genetics of the cancers or the clinical features haven't really revealed a true understanding of why we're seeing this rise in early onset gastric cancer. So moving on to one of the other potential explanations is genetic factors. So is the risk for early onset stomach cancer inherited? And what I had mentioned earlier is that we don't necessarily think that explains all of the cases. Specifically, one of the more common mutations that causes stomach cancer, CDH1, wasn't necessarily dramatically enriched in our data set in the younger patients. So what I've shown here are two figures from two different studies that came out of Sloan Kettering. The first on the left is from the data set that I had shown earlier. And what we're seeing here is early onset on the left, average onset on the right, and looking at frequency of inherited mutations. And they're classified by penetrance, which means if your parent had the mutation and you inherited it, what's the likelihood that you're going to develop, you're going to have that, the disease develop based on having that gene type. And there's no real difference, a slight higher proportion of germline mutations in the early group, 20.7% compared to 16%, but it's not significant. But what we do see in a study that was done by one of my colleagues, Dr. Koo, and published in 2021, is that if we break this down by esophagus, gastroesophageal junction, and then stomach, shown by the lowest bar, there's a much higher proportion of high penetrance inherited abnormalities in those with early onset stomach cancer compared with esophagus and gastroesophageal junction. So these were all young patients under age 50, and you can see it's still a relatively low percentage. So the bar here is showing us it's only even about 10% of patients with stomach cancer that have those mutations. So the takeaway is that we should definitely be looking for inherited gene mutations in anyone who develops stomach cancer under age 50, but it's not likely to explain the majority of cases that we see. And then just some additional information from that same study is that when we look at what are the mutations that are inherited in early onset stomach cancer, we're seeing the CDH1 mutation that I mentioned here, and these blue-gray bars are the stomach cancer, whereas the darker colors are the esophagus and gastroesophageal junction. So we're seeing the CDH1 mutations, but we're also seeing BRCA1 and 2 and ATM, MSH2, so a variety of other mutations that are inherited. So limiting the testing to just CDH1 is not recommended either. And then lastly, moving on to, or second to last, an additional possible explanation for these early onset cancers is diet. And I didn't dive too far into this because there's a lot of data out there and a lot of it remains unknown. But there have been some larger studies looking at dietary factors that can play a role in developing stomach cancer. And this is from a meta-analysis, meaning they looked at many studies, about 76 prospective studies, many thousands of patients to try to see which dietary factors were associated with developing cancer. And you see that protective factors are, interestingly, white vegetables, total fruit intake, and vitamin C. And then high-risk factors, which are not so surprising, are alcohol, specifically beer and liquor, salted food, and greater than 6 grams a day of salt intake. And the interesting component here, which we also see to some extent with dietary exposures in colorectal cancer, is that the risk increases with your exposure. So the more, it's not just a binary, more than 6 grams of salt intake per day is worse than less than 6 grams per day. The more salt over 6 grams a day you have, the worse the association, so the higher your risk. So I think it does speak to something that we often counsel patients about, which is everything in moderation, but it also speaks to the fact that there are probably some underlying environmental and dietary components playing a role in stomach cancer overall, but we don't know yet if these specifically are increasing the risk of early onset stomach cancer. And then lastly, does chronic disease play a role? So there are many chronic diseases affecting our population at this point, including obesity and diabetes, hypertension, high cholesterol, heart disease. But I called out specifically data from one study which looked at combined results based on a number of different studies, similar to what I showed with the dietary exposure, and showed that there is a statistically significant link between excess body weight and stomach cancer. But again, this is not specific to early onset stomach cancer. This is stomach cancer overall. So what you're seeing in this table is there's, compared to those who have a normal body weight, those who are overweight or obese have about a 1.2 times risk of developing stomach cancer compared to the average weight individuals. So, and the strength of this association increases with increasing BMI. So the higher the BMI, the higher the risk. Body mass index. So again, additional food for thought going forward, but doesn't necessarily explain what we're seeing. So to wrap up with the third part of the discussion, trying to leave a little time for discussion at the end, is what are some patient-centered strategies on the horizon? And unfortunately, at this point in time, one of the most important things we can do for all of these early onset GI cancers including colon, rectal, stomach, and esophagus, is encourage patients and individuals to be vigilant about common signs and symptoms. And I think especially I've seen many young individuals come through my clinic who developed advanced cancers, and some of them did have symptoms for quite some time that were attributed to other factors, which is very reasonable given that most young people don't have cancer. But I think being aware of what are some of these concerning signs like fullness, indigestion, nausea and vomiting, unexplained weight loss, swelling of the abdomen, pain, that could be signs of stomach cancer, and making sure that both patients and providers are aware of this and do the appropriate testing when indicated. Similarly, for esophagus cancer, I've listed here some of those common signs and symptoms. And then the question always comes up, should we be screening for these cancers? And there's no, except in those who have a predisposing genetic condition, there's no data to support the use of screening for stomach cancer. And screening for esophagus cancer is recommended only in a very specific group of patients. So those who have at least 3 risk factors, including male sex, non-Hispanic white, age over 50, smoking, obesity, reflux, or family history of Barrett's esophagus or esophageal cancer. So this does hit a surprising number of individuals if you look at male over age 50, non-Hispanic white, but it still doesn't reach the majority of the population and does not at all cover those under age 50. And just a quick note about what that screening would look like. There's non-endoscopic screening, and there's also endoscopy, which can be used for screening for esophagus cancer. But again, this is not for stomach cancer, and it doesn't address patients under age 50. So how can we focus on the needs of these patients under age 50 if we know that these cancers are rising, but we don't yet know the etiology? So one way that we've addressed this is from a figure that we published a few years ago about our Center for Early Onset or Young Onset Colorectal Cancer at Sloan Kettering. And what you see is that this is really an integrated multidisciplinary approach. So on the left are all of the clinical resources that we think are relevant for patient-centered care. And on the right are all of the research components that we think are relevant. And those really combine together into a center where we're addressing both the need to study these diseases, but also the need to provide the best possible care for patients who are young and going through these difficult diagnoses and treatments. And what we ended up doing is expanding this to make a coordinated center to meet the needs of patients with any early onset gastrointestinal cancer. So again, colorectal cancer has been in the news, has been the topic of discussion, but the reality is that stomach cancers and esophagus cancer and even pancreas are affecting younger and younger individuals. And we need to focus both our clinical effort and our research efforts on better addressing the needs for these patients as well. So this is an effort that we had implemented at Sloan Kettering, and we're actually in the process at university hospitals in Cleveland of establishing a similar program addressing the needs both clinically and investigationally for early onset GI cancers and inherited cancer syndromes. So in conclusion, we talked about a number of different components of the problem of early onset stomach cancer. We know that early onset GI cancers are rising globally and associated likely with this birth cohort effect that I discussed. The etiology is likely multifactorial with potential contributions from diet, microbiome, chronic disease, inherited genetics, but really not fully understood at this point. Screening definitely is not the complete answer to the problem. And individualizing cancer-directed therapy, we know can reduce toxicity and potentially improve outcomes, but we have to remember, especially as we're seeing younger and younger individuals, that one size doesn't fit all. And we have to really create an infrastructure for multidisciplinary care involving different specialists to provide the best possible care for each young individual who walks through the door. And so what's next on the horizon? As I mentioned, this prospective biospecimen platform to try to define associations between diet, blood markers, the intestinal microbiome with the risk of early onset GI cancer, trying to better understand how we can target peritoneal disease, given that this is disease that's occurring in the abdominal cavity, disproportionately affecting young women with stomach cancer, and a problem that's really difficult to fix surgically or medically. Manipulating the intestinal or the oral microbiome to influence risk and response to treatment, trying to expand screening programs to increase uptake among those who are eligible. So I said screening is definitely not the answer, but it certainly is reasonable to try to make sure that all those who are eligible for screening undergo the appropriate screening. And then, as I mentioned, I do believe that dedicated centers for early onset gastrointestinal cancers will help on both the clinical front and the research front. So I'd like to just acknowledge many of my collaborators, both at University Hospital's Simon Cancer Center in Cleveland, as well as my mentorship and collaborators at Sloan Kettering, and the funding that I've received over the course of the past several years from several different organizations and internally at Sloan Kettering. And then most importantly, patients, their families, and their advocates like all of you. So apologies again for the coughing mid-presentation, but thanks so much for your time, and I really look forward to hearing any questions or comments.
Dr. Lumish, thank you so much for sharing with us today. We did receive some questions. I'm just kind of putting up the screen right now for that so I can get to them. And please continue typing if you do have questions, and we'll get to them as we can. Please visit our DDF website for more information on upcoming events and programs that are listed here. And other than the questions, this concludes today's presentation. And so we're gonna, I have the screen right here, but I'm gonna go back to the question thing to remind people how to get to the questions, and then I will get to, to the question aspect. Okay, all right, so one question that came through was you had said that screening was not going to be recommended, but with H. pylori being so prevalent as a risk factor, why aren't more doctors testing for H. pylori during yearly visits?
Yeah, it's a great question. I think it's more prevalent in certain parts of the world as well. So there definitely are individuals who should undergo H. pylori testing. And also, if patients have symptoms, they definitely, like reflux or are undergoing endoscopy for another reason, it's definitely reasonable to check for H. pylori. I think the reason I say screening is not recommended is because screening with, let's say, an endoscopy isn't going to address the problem for the majority of patients, because you'll end up doing a lot of unnecessary endoscopies. But I think the main reason we don't broadly screen for H. pylori is because the prevalence in this country of that bacteria has gone down significantly in the past several decades. But individuals specifically who are born in other countries where that may not be the case definitely should get H. pylori testing.
Thank you very much. When another question that came through was, when I was diagnosed with H. pylori, I was never given any indicator that this could cause stomach cancer. I was just given a prescription, and there was not really any follow-up except for finishing my medication. What can we do to have general GI doctors and primary care doctors understand the importance of following up to make sure that this is eradicated?
That's a really, really interesting point. I think a few things come to mind. First, advocacy groups like, this group here, broadening the discussion and making sure that we have a voice in as the patients to, even inform our own providers, like that we learned about X, Y, or Z from whatever, educational things we've gone to. But then I think it's our responsibility as a medical community to try to keep the discussion about the microbiome and bacteria that live within our bodies going, and continue to broaden awareness of the fact that this is a real component of health and disease, and that and maybe even include in some national guidelines which bacteria have known associations with cancers, and how we can make sure to confirm eradication of that bacteria in individuals who test positive. And it kind of makes me think to some extent about like human papillomavirus, HPV, and its association with cervical and other cancers. We make a very adamant effort to continue to screen patients with frequent pap smears who have HPV, to vaccinate people against it. So why shouldn't we have the same attitude towards bacteria that are known to be harmful? I definitely think we should. So I think the discussion has to come both from the patients up, patients to providers, but then also the medical community as a whole, I think needs to kind of increase that discussion, if that makes sense.
Great. Thank you very much. And therefore, I know we are at 1 o'clock now, but for a final question, do some stomach cancers grow faster than others?
Yes, I don't know that we have a sense of exactly which ones grow faster than others, but there are definitely some different biology for different cancers. So, and there are also some cancers that are more likely to grow and stay within the place where they started, and some that kind of have more of a propensity to spread, like I was saying, to that abdominal cavity or to other sites in the body. And I think understanding the biology and how these cancers grow differently is going to be really important in helping to improve our treatments and also better understand what types of testing are needed for patients, especially these young individuals.
Thank you very much. I know we are out of time, and for any more questions that are in there, I will send to Dr. Lumish to get them answered. And if you have any others, you can feel free to email me as well. I just want to just to remind you guys of our upcoming events. We have some really exciting new events coming up in the next year, and then to again thank our sponsors, platinum sponsors Bristol Myers Squibb, Merck and Taiho Oncology, bronze sponsor Arcus Biosciences, silver sponsor Amgen, and copper sponsor Lilly Oncology. To view any of our recorded webinars, please visit our lecture library or our website at www.wstream.org. Thank you again for coming today. This concludes our presentation. Have a good day.
Thank you.